Welcome, everyone. We are so excited this afternoon to learn more as we are in the part 3 of our ONH series. This is going to be completely jam-packed. So with that, I'm going to hand it over to Sarah and Julia, who will take over and introduce the panel as needed. Thank you both for today.
Hi, everyone. I'm Julia Bowman. I'm a birth to 3 teacher at Illinois School for the Visually Impaired. I'm here with my coworker, Sarah Edwards, also a birth to 3 teacher at ISBI. And today we're going to talk about collaboration in EI for students with optic nerve hypoplasia. As Melissa mentioned, this is part 3 of our series on ONH. So what I'd like to do first is give us a recap of parts 1 and 2, and then we'll introduce our guest speakers that we have as we go through the presentation. So in part 1, we really discussed the medical aspects of ONH. ONH is a complex medical condition that causes visual impairment, but it doesn't stop there. There are non-visual associations that include neurological, endocrine, and behavior differences that are medically based. And these differences can manifest as developmental delays across all domains or sensory processing issues. These sensory issues become very important because sensory dysregulation then can affect social and language development. And as we talk about in great detail in part 1, that sensory information can just overwhelm these students to the point where they can't take in information successfully. And finally, because so many of the behavioral issues overlap with autism, we want to make sure that careful assessment is performed when autism is suspected in this population. In part 2, we talked about strategies to support our little ones with ONH and their families. Now, each child is unique, so we really start with their strengths and their challenges, but there tend to be basic core areas that we focus on, and these include behavior and sensory needs. As I just mentioned, sensory is such a big part of how these kiddos learn. Social skills development, because especially in birth to 3, learning is so socially based. Language development, because of the issues with taking in information, that receptive language can be affected, so we need to support language development. And finally, visual needs. There's such a wide array of visual abilities in this population, and so we need to focus on either tactile or low vision strategies for both home and in the classroom. So today we're going to focus on our teams. Whenever we work with a little one in EI who has optic nerve hypoplasia, our teams are often very large. They, of course, include us. In Illinois, we're called DTVs, but most of you will recognize teacher of the visually impaired as this role. But we also have physical therapists, occupational therapists, speech language pathologists, or feeding specialists, or both, orientation and mobility specialists, and then others. And I put a question mark because each child is different, each family has different needs, but we often see nutrition, we might see counseling, family support, parent to parent, social work, behavioral support. It really depends on what that child and family needs. So for consistency, we ask the same 3 questions of each of our guest speakers that we're going to have here today. What are 2 discipline-specific issues that you have observed in children with ONH? What are some strategies that you found successful with these children? And then does working with a DTV or a TVI change your approach? And if so, how? So we're going to start with gross motor development. And I'd like to introduce to you Michelle Ewan. She's a physical therapist here in Central Illinois and an EI specialist. And she's going to talk about some topics that come up very often when we work together with a little one with ONH. Michelle?
Thank you, Julia. As she said, my name is Michelle Ewan, and I'm a physical therapist, and I've been working with Julia for about 10 years now with early intervention. My primary caseload is birth to 3, although I see children all the way up to the age of 21. So when talking about really those 2 issues that she had asked us about, with talking about children with ONH and visual impairments in general, is really thinking through motor development and kind of how we learn motor skills and what we learn. So, this little guy in the picture, we're taking Christmas card pictures, and, this is the face he gives us. And when we think through, everyday motor development of what we do and how we learn things. Other motor skills like running, walking, sitting, we do every day. But if you really think back to how we learn them, we imitate, we practice, and we give feedback. So here's his Christmas card picture, and you're pretty sure he probably learned this from his bigger sister as, going through. So when you're thinking with these children who have these visual impairments, we really learned visual movement because we watch others. And now this is something that, these children don't have these experiences. So we really work together with the developmental vision therapists or the teachers of the visually impaired to kind of work through and find these experiences for them, and also with orientation mobility specialists to facilitate that motor progression. We also then move through to talk about more complex things like assistive technology or assistive devices or orthotics, push toys and walkers, and also how we set up our home environments for safety, and then also kind of safety suggestions within the home. So I'm going to talk a little bit more kind of on that end of things here coming up. So looking at orthotic footwear, a lot of our kiddos with ONH or other visual impairments might have secondary concerns from a motor standpoint. And through working with Julia and Sarah in the past, my end really is looking at that overall kind of muscle tone, and also how do I support that development of that child in terms of that, how that foot develops. So in terms of ossification of the foot, typically we have until the child's 6 or 7 to really develop those bones. So before that age, the child's foot's really pliable, which means there's a lot of movement of the foot and the bones aren't really solidified. So that means that I actually can build an arch, I can kind of develop that foot. But now if you think about good alignment and all of those things that go in, I have up until that 6 or 7 point before those bones kind of form and really create kind of that foot that child's going to have for life. So a lot of times we do implement orthotics, but now when you think about your basic balance, we have 3 things really that come into balance. We have what we see, what we feel, and then we have the vestibular, which is your inner ear. So with a child with a visual impairment, you already are kind of at, you're missing out on the vision input. And now by putting braces on a child, you're taking out that proprioception or what I feel through my feet. So the braces all the way on the end are kind of your classic AFOs or the full foot plate. But maybe that child still needs that arch support. So we've been able to get a little bit creative with some of our kind of our orthotics with some of the kiddos. So the second kind of row of pictures that you can see there, they actually have the toes cut out. So these are SMOs on the top, and then the bottoms are Sure Step orthotics, which also have the toes cut out, but they are full AFOs, ankle foot orthoses. So if their toes do roll in, or if their feet do roll in, or kind of the toes come in, or there isn't an arch, we can use those, but still give them some input through those toes. So I'm not totally taking out that proprioception if it is appropriate. Your other option is that, if I can get away with an arch support, maybe instead of a full foot arch support, I can also do an arch support that will kind of stop before that toe. So again, they can have some input. And if I can get away with some kinesio taping or things like that, I may also be able to find a way to kind of use kinesio taping for some alignment. A lot of kids, kinesio taping isn't quite enough for that child. It just depends on how big and strong and kind of what I'm trying to get from that child in that alignment. Also, can they tolerate it as well? Tolerance is really key, and how do I introduce it? So there's kind of a twofold approach to orthotics. One is I'm taking away the floor. So I'm taking away proprioception for that child with their balance. I know Sarah and I have talked in the past with some kiddos, and her philosophy is always, if the child needs it, we're going to do it. But then we also need to make sure that we're giving them other strategies in terms of, how am I going to make sure that the child still is able to feel and work through their balance? Because I am, from a motor standpoint, now taking out one of my 3 balance strategies that is really important to develop balance from my end. For example, I'm not going to be able to feel, the transition. So if I can do an AFO where it's still appropriate that I can feel the transitions in the floor and things like that for balance. Or, can I get away with, just kinesiotaping, and can they tolerate that? The other option is footwear. So for some of my really little kiddos, we might start with a slipper with a rubber bottom. So really the goal of shoes, if I'm doing orthotics, is for traction. So for me, the orthotic is doing all the support of the shoe. So these orthotics are really providing the support for the arch, for the alignment. So I'm really looking for something that's traction, it's going to support. I need them to open up. The top ones are actually water shoes that I've used for a couple of the kiddos. They have to open up wide enough. The downside to them is you're putting plastic into them. They don't always hold up as well, but they will give you traction for your brace. And if you can get them to hold up, you can slide the brace right into that, and then they can really, get that traction and input. And again, these are for my really little kiddos that are walking around at home, not my school age kids who are, going to school and things. And then the bottom picture are a pair of slippers that again have rubber bottoms, but you will be able to feel, mild changes to the floor, hardwood to carpet, things like that through them. Because again, I don't want to take out, we're already missing, the vision for a balance strategy. So if I can give them any other input. And the other thing I'm looking at is, flexible foot plates. So how thin can I make the plastic under their foot so that they have some flexibility for those balance strategies as well. The next area that I do think is really important is positioning. So if you think about, again, how I'm going to set these kids up both for whatever other homework, positioning, things you're going to be doing, mealtime, learning, how can I really give them input? Positioning is going to be key. So these are the one side is kind of makeshift things you can do at home. The other side is commercially available things that you can buy. So if you're thinking about positioning for a child like at mealtime or at a table, so this is a commercially available booster. And then underneath, you're going to have a chair, and that's just a kid's chair. I have him set up at 90 degrees. I have the chair right under his feet, and I'm giving him input. So you can see right where his feet are right on the chair. And then he knows exactly where his feet are in space. He knows where he is in space. The other one is a high chair. So a lot of the high chairs, unfortunately, don't have very good alignment. And even if they do, a lot of times the foot plates are way too low for the child. So pool noodles are a big favorite of mine. Dollar store has them all the time. You can see the baby in the middle picture. A lot of times I'll use painter's tape, and I'll just tape them on because it comes off really easy. It won't usually damage your high chair. The other one is actually just a towel roll, and those are bag clips that are attached to the towel roll. Again, things that you find at somebody's house very easily, and that you can just kind of give, again, some input. And these are things that, on home visits that are really easy just to implement while you're kind of looking for more permanent fixes. But a lot of times it's kind of what you have available. And your goal is really to get that input through the feet so that they know kind of what they're doing. If you think about, there's a typically lower kind of core strength, trunk strength. So if I can give them input through their feet and really support the core, a lot of times I'm going to have better reaching. I'm going to have better tolerance to activity. I'm not going to have quite as much wiggle for whatever activity or mealtime or things I'm doing as well. Most kids, again, you're going to just have that input. That input's going to give you just more core strength and more ability to focus on other things, whether it's speech or OT or feeding or other things you're trying to work on. The other area that I think people don't always think through are car seats. And again, this is a forward-facing kiddo, and this is a commercially available product that has a foot plate, and it actually kind of goes down through the floor. You do have to be careful because not all of these are obviously crash tested and things like that. But this is just a step stool right there on the floor that gives him some input through his feet. So if you think about car seats and vestibular movement, there you are moving and you have no idea where your feet are in space. So that is something that's going to give you, a little more input for, where my feet are. And then this is a seat for at the table that again has nice alignment at those knees, that this little one has their feet at the table, a little bit less trunk support than like your high chair, but has really good alignment there. Knees are at 90, feet are on the floor, right up to the seat. So kind of picking your chair and kind of how you set them up is going to give you more input for that child to be able to do other activities as they're ready. The other area that I get asked a lot of questions about is kind of adaptive equipment and how do I pick, where do I pick, and kind of where to start. So for a lot of these kids, especially just in PT in general, for all children, I get asked a lot of questions on, do I use a push toy? When do I use a push toy? Do I not use a push toy? So for just your classic baby walker, I get asked, do I use one? Do I not? And so those are the ones that go in front of you that have usually, toys and things on the front. They are a little less stable. They fall over sometimes. They do encourage kids to lean forward, but there is the advantage that they are age appropriate and they're fun, and they are a good option for your kids that are the right height for them. Now, for our kiddos that walk a little bit later, a lot of times they might end up being too short for those kids, things like that. So something like the cart in the top picture on the right, those are sometimes a good area to start with some of these kiddos, because again, it gives them something in front. They are going to be leaning over a little bit, but it will give them a little bit of input on things kind of moving in front of them. And the general rule that I kind of use when picking an device is the child really should be comfortable, and the device should be about waist height. We also get asked, anterior walker, posterior walker. So anterior walker is going to be the young lady in the first picture, or in the middle picture where it's in front of her. Posterior walker is going to be the girl with the purple walker with the one behind her. From a PT standpoint, I personally always like the walkers in the back because typically it gets them up in a little better alignment. But sometimes with children who do have visual impairments, I will put the walker in front of them because it does give them a little bit of that guiding. And that's where I usually work with orientation mobility, and we kind of talk through, how can we put something in front of them? How can we give them a little bit more guidance to kind of know where they are in space. And devices should generally improve the child's gait. And in terms of safety, it should help them find a clear path from one location to the other. So sometimes this is a little bit of trial and error for the child. So if I have a child that's really leaning forward, maybe we do need to switch to something behind them. But, a lot of children, if it's just they need some input in the front, we'll just switch the walker that they need. As far as using the equipment, a lot of times we just have to, get the child to tolerate the equipment first. So sometimes this isn't as easy as it's never as easy as you just give the child the walker and they, just take off and use it. A lot of times I'll bring the walker out to my first PT session and I'll just leave it out in the environment. And I'll tell mom, don't have expectations, just leave it out, let them explore it. It's going to be cold. It's going to feel different. We're going to let them kind of explore it on their own. Now we are going to teach them to treat it in a respectful manner. We're not going to let them throw it and bang it and swing it in the air and throw it at people and things like that. We're going to develop techniques then so that they learn how to get in it, how to hold it, how to grip it. And we're going to label the parts of it as we start to implement more. And then once they can tolerate it and they kind of understand, then we're going to actually start walking with it through their environment. So sometimes this is a little bit of trial and error from a PT standpoint. It's just more, first we got to get used to it and see, because the tolerating it is going to be the first point. And then from there, we're going to actually implement the use of it. Once they can tolerate, we're going to learn to walk on different surfaces, terrains. We're going to teach them changing directions, elevations, different surfaces, stopping when they kind of get in contact. And that's usually when I'm working more with developmental vision and then the orientation mobility for kind of how we're going to implement those sorts of things, to teach them how to use it within their environment as well. And then these are some of the different, adaptive seating that we often use. And these are things that are more commercially available. We work with a vendor in the area that we order the different equipment through. So the special tomato seat is usually one of the first sort of seats that we will order for a child. It again, has different sort of bases and things. So this is the one for a little bit older child, but it's got nice support. It's usually got a 4-point harness. Again, this picture, he's got nice contact with the floor. This one's got a rolling base. There's ones that have ones that don't roll as well. Roofed-in activity chair is nice. It's got a tray that comes on and off. Again, good foot contact with the floor. K-bench is a little bit older style, but honestly, I still really enjoy the K-bench. The downside is they are a little bit heavy, so usually used at home, not as easy to be taken to different places. Kimba strollers are also very nice. They have trays, things that come on and off, so you can do activities and things for that. And then the tumble form seat is there as well. So those are, again, a little bit of an older style, for that, but we actually use them quite a bit. The special tomato seat, I feel like, is used a little bit more now than the tumble form is, but we still use both of them pretty evenly in early intervention, just depending on what the child needs. And looking at all these, I think the biggest takeaway is that, you have good foot support, good trunk support as you're kind of looking for what that child needs to give them that input. So.
Okay, thank you, Michelle. So we will move on to orientation and mobility, and I would like to introduce Carol Otten. She primarily works up in the northern Illinois area, but she is ever so kind, and she comes down into my and Julia's area to help us out here in central Illinois as well. So Carol, I will hand it over to you.
Thank you, Sarah and Julia. My name is Carol Otten, and as Sarah said, I'm an orientation mobility specialist. I'm a COMS, which is certified. I am retired from working with school children, and for almost all of those years that I was working with school children, I was also working in early intervention. I've had a lot of experience working with Julia and Sarah, and as Sarah said, they are a little bit farther away, but since we had the pandemic in Illinois here, we were able to do some things with live video visits. And so I'm happy to say that I'm working with some families who don't have services for orientation mobility. And I've actually had the opportunity to work closely with some of their PTs and with their DTVs. And we co-treat as often as possible. Oftentimes it works well when either Sarah or Julia is in the home or the PT, and I jump on their sessions with them. So in looking at this, we're looking at early intervention, children with ONH. And when Sarah asked me to do this, I said, let's see. I think I work with children with ONH the same way I work with all of my children in early intervention. But specifically, there are some things, as Julia mentioned at the start, some core areas that we see, especially early on with children with ONH. And as also mentioned, all of our children are so different and they are unique. And so we have a lot of trial and error through some of the activities that we're doing. And Michelle did such a great job of talking through the PT portion. It's pretty typical for a physical therapist to start, jump on board. I find that I'm called in oftentimes a little bit later. There's usually a DT vision and then a physical therapist and an OT, and then they bring me along. And this is where we start working together and collaborating on activities and things to motivate. So talking about the three things that we see, I find that children specifically with ONH tend to lack initiative in exploration of their environment. They follow rigid routines, which sometimes results in a difficulty with transitions. And we all see that they often are seeking sensory stimulation and vestibular input. So with that being said, I'm going to give you some more specific strategies. Again, same strategies that I would share if I was doing a presentation on early intervention O&M, but specifically we find that sometimes our kiddos with ONH need to have some favorite motivators. They need a little bit of sensory stimulation and vestibular input before they get going. So we need to identify significant and favorite motivators, which typically would have an auditory and tactile component. They also will have a visual component. And so many of our children have a variety of visual acuities. Some may see better than others. So we're going to include all of those components. There's so many great toys. I learned about so many toys from my families and also from visiting with these co-treats with some of my other therapists. But we want to consider toys that vibrate. And I recently was able to Google about toys that motivate rolling and crawling. And actually, there's a lot of toys out there now specifically that are developed for crawling and to motivate kids. Now, oftentimes these are going to be visual toys for sighted children to get them motivated, but they also have a visual and they might have lights, they might have auditory. And so we're going to really practice with those toys and to keep them motivated. When we talk about the transitioning, we want to talk about the verbalization, as we do with every child, of letting them know when things are happening. We can never verbalize too much for our children. I love when parents send me videos. I often ask for videos prior to doing an assessment, and they'll send some videos. And honestly, just today, I received a couple of videos from a family, and throughout the entire video, I was supposed to be observing the child, but the mother was verbalizing everything. And it was just so perfect because the child was able to learn from what she was telling him and also what was going on and what some of the observations were to be. And that also helps with transitioning. So we want to provide opportunities for practice during daily routines. I'm sure in other states, as well as here in Illinois, our early intervention program is really geared towards us providing services and suggestions and strategies for families as they move through daily routines. So when we look at orientation and mobility, we talk about, when you're in the kitchen, turn on the faucet. You're going to have the dishwasher come on. You're going to talk about the things that happen in the kitchen. If you're going to go to bath time, you want to turn on the bathtub. You want to talk about the tile on the floor, that it might be colder than the family room floor that might be carpeted. So when we're going to move to some of these places, like towards diaper changing, or we want to move to the kitchen for a snack, this is when we want to practice the skills that we've sort of instructed the families and that they've learned along the way. We want to encourage exploring and moving to find things. We don't just want to explore and move. Sometimes we do that when we're learning to trail or when we're moving around a room. But if we're really looking to motivate a child to find something, if they have a favorite basket of books or some favorite toys, we need to move them a little bit further away so that they'll move towards that, and we show them how to do that. I find with some children who aren't crawling, but they're able to sit up, we can use a floor scooter, a little rectangle floor scooter or a square one. A lot of times you find these in preschool, children use them in the gym. You can use a floor scooter if they're sitting, and we can at least let them understand that they can move from one place to another. We love ride-on toys. Ride-on toys are another way for children to move around if they're unable to walk at this point. And they, again, will also, as Michelle mentioned, we'll look at the addition of a toddler walker, a grocery cart, perhaps a lawnmower, things that we use for a tool that would be something that would provide them with information about the surface that they're walking on. So we need to find what it is that motivates the child. Sometimes there's a favorite lawnmower that might have a sound, and that might keep the child moving. We verbalize, as mentioned earlier, when the child is rolling or crawling or walking towards an object or a new floor texture. Maybe they're transitioning from a carpet to tile, or from the living room carpet to wood floor in the kitchen. And even if you're not standing next to them, you can verbalize to them when that happens. We want to use the sounds, the smells, and the texture changes to identify specific rooms. And again, when I look back at specifically talking about the transitions, we're going to sometimes use a timer if necessary, like we're going to turn on music, and when the music stops, we're going to change to a different activity, or you're going to put a timer on, or maybe you're just going to sing a song. And when the song's over, mom is going to pick you up, take you out of the high chair, and we're going to play on the floor. So it's working through some of those routines and finding what actually motivates the child to keep moving. Another area we find, I find typical of ONH is that some of the children really need some sensory stimulation and vestibular input prior to a motor activity. And I have learned so much from working with the physical therapist that this could be a deep massage. Like we could go and I could sit down and I could say hi to the child. If I've just arrived, we might sing row, row, row your boat, sit on the floor and row back and forth. We might just say good afternoon or good morning and talk about their body parts, and at the same time do some deep massaging. Bouncing on a large yoga ball is really great. And also I've done some things with swinging in a blanket. Have two adults and the child in the blanket and swinging back and forth. And a lot of this is just to get their body going. Of course, you can use a swing. I love a child's rocking chair. And of course, the sit and spin. And one of our favorites with my early intervention families is the Fisher-Price bounce and spin, and it's a puppy. And when the child practices getting on it, and then it spins around and around in a circle. And there's so many concepts that we can work through when we're talking about orientation mobility. When I work with a physical therapist, I really allow them to show me what are the kinds of things that we need to work on in terms of strengthening. We're talking about core. We have a lot of children who don't crawl who are visually impaired. They may start walking before they crawl, but we know that crawling is so important for developing the strength in their core. So again, there's other activities that we can do if they're not crawling. We talk about walking along the wall, pulling to stand, doing some trailing along the wall. Oftentimes I use Lego tape, which it comes in a roll. You can buy it on Amazon, Walgreens, the pharmacy sometimes has it. It's sticky on the back, so you can put it across the wall, and a child might enjoy the bumps on the tape to be able to trail. You can use painter's tape, as we talked about earlier. That's another texture that children might enjoy. It's just finding what really motivates them to keep them moving. A couple other things that I think about ONH children I find is that they have a strong interest in music and rhythm. So whatever way we can incorporate music and rhythm into an activity, we're going to do that to keep their attentiveness and to keep them interested. And I think that we find processing takes a little while. So we might introduce a concept, but we have to remember that they need time to process and not to be in a hurry. So sometimes I think that happens all the time when we only have maybe a once a week visit or every other week visit, and we're in a hurry to kind of get through some activities. But I find that allowing time for processing is very important. And as I mentioned earlier, the point about co-treating. So I think in Illinois, and I'm hoping that in other states, we have the opportunity to do a lot of co-treating with other therapists. And one of the questions that Sarah and Julia asked us was, did we find it to be beneficial? And I find for it to be beneficial to co-treat, of course, with the DTVs and the vision teachers. I am a vision teacher as well, so we can work together really well. But I also find that we learn so much more when we have the opportunity to work OT, PT, and speech within our sessions. I think it's important for all of us to sort of see what's working. So it doesn't change my approach when I'm working. I love to share all my knowledge, and I love to learn from the others. So if you have specific questions, you are welcome to email us. I'm going to give you my email address in the chat in a few minutes. I see one question, and it said something about Lego tape. It's bumpy. It looks just like, oh, what was that question? Let me look. It's called Lego tape. That was a question in the chat. So it comes in different colors, red, yellow, blue. You can find it. And if I can find a quick link before it's over, I can put that in the chat as well.
Thank you, Carol.
Look at
And
that.
I did notice that somebody had asked about a belt cane too, so I don't know if you want to touch on that maybe after. We'll let the other ones get through using a belt cane.
Yeah, it's up to you. Go ahead. I can do that.
Okay, so I will go ahead then. Thank you again for sharing the information, and we'll come back to you and let you touch on that question. I'm sure there'll be others. So we will move on to Sarah Alter. She is an occupational therapist and has worked in the Chicago area, I believe, and she's now down in the central Illinois area. And I have had the pleasure of working with her recently with a couple of children in early intervention. So Sarah, I will pass it off to you now.
Thank you, Sarah. Like Sarah had mentioned, I'm an occupational therapist. I work in early intervention primarily, so most of my kiddos are between the ages of 0 and 3. So I'm going to go ahead and talk about some of the sensory challenges that are typically seen in kids with ONH. So some of the most common sensory behaviors that I've seen are sensory seeking and sensory sensitivities. So our sensory seekers might be seeking out more of that vestibular input, like Carol had mentioned. So vestibular input is essentially just movement. And so these kids might have a really high activity level, always be on the move, jumping, rocking, bouncing, that kind of stuff. They might seek out proprioceptive input, which is essentially just deep pressure input or heavy work input that is received by the muscles and joints in the body. So those kiddos might like to squeeze their bodies into tight spaces. They might really love like sitting in their parents' lap and like lots of snuggling, lots of cuddling. They may be climbers. They might do a lot of like pushing, pulling, dragging, different like heavy things around. And then sensory seeking can also show up as oral seeking. So these are the kids that do a lot of mouthing of toys and non-food items, chewing, biting, that kind of thing. And then I'm going to talk about sensory sensitivities, focusing mostly on tactile sensitivities. So that's just kind of sensitivity to different touch or texture experiences. All right, so for working with sensory seekers, the way that I kind of address their sensory needs is the first thing I do is I figure out what type of sensory input that kiddo is seeking out. So every person has their own sensory system with their own sensory needs. Our kiddos with ONH, each kid is different. So looking at the behaviors or the activities that they are doing and really kind of analyzing what type of sensory input that activity or that behavior is providing their nervous system with. So once I figure out what type of sensory input they're seeking out, I find ways, and this is kind of trial and error, I find ways to provide that type of sensory input in a structured way. So if they're seeking out movement input, then I find a structured movement activity to help them meet their sensory needs. And then I incorporate those sensory activities into our therapy sessions. I usually start the session with more of a sensory-based activity to help them get their sensory needs met before kind of moving on to, the seated play or working on anything that kiddo finds less motivating or more challenging. So the kiddos who are sensory seeking and they seek out a lot of that proprioceptive deep pressure input, we give them lots of deep pressure input. So in general, just knowing that proprioceptive input is really, it's kind of the go-to. Giving kids deep pressure input is going to be helpful for their self-regulation overall. If they're seeking any type of sensory input, giving that deep pressure input can be regulating, even if they're not seeking that deep pressure input, if that makes sense. So some strategies that I use during sessions and have parents do at home with their kiddos, deep pressure massage, joint compressions, using weighted items. So that might be a weighted blanket, a weighted lap pad, wearing a weighted vest for short periods of time. Compression garments like a compression shirt, and just, toys that provide resistance that require kids to push or pull or drag or lift. So that might be like a weighted ball that they can push, and that gives some resistance to their body. It might be like pushing together like those big pop beads and pulling them apart, because using your muscles to pull something that is a little bit like difficult to pull, that gives deep pressure input. For oral sensory seekers, we do lots of oral activities. So we've got chewy tubes, oral motor tools, having families use vibrating toothbrushes when they brush their teeth, making sure that like snacks and meal times can incorporate crunchy or chewy foods, because that just gives more input to the mouth than other types of food. Straw drinking, especially drinking like thicker liquids like smoothie, or even something like applesauce through a straw, can be a really good oral activity. And then for vestibular seekers, movement seekers, we do lots of like sitting and bouncing on a therapy ball, rocking side to side on a therapy ball. I have like an inflated cushion that I'll have kiddos sit on so they can like kind of wiggle and move around a little bit when they're sitting to play and working on other activities. For our kiddos who are not jumping yet, I'll help them to jump. So like putting your hands under their armpits and doing these big exaggerated jumps to get them lots of that movement input. Like Carol had mentioned, doing blanket swings to adults, turning a blanket into a little hammock. And then some kiddos also really like head inversion. So sitting on the couch with the kiddo in your lap, you can have them like tip their head backwards over your lap to kind of hang their head off the couch and then pull them back up. And then I'm going to move on to talking about strategies for kiddos who are sensitive to tactile input, different textures. So when we're working on improving their tolerance for different tactile input, I make sure to incorporate lots of proprioceptive input before and during tactile play. So just a reminder, that's that deep pressure input, because that is the universal like regulating input. So we want to make sure that as we're kind of exposing the kiddo to different input that they are more sensitive to, that we're also helping to mediate their response to that type of input. So in our sessions and at home, I would have kids work on just being exposed to different textures and different touch experiences frequently. So I start small and I follow the kiddo's lead. So some of the strategies or activities that I use would be like, we start with dry textures before we move on to introducing wet or sticky or messy textures. I typically don't start with something like Play-Doh. I would rather start with like dry pasta in a bin. And that leads us right into sensory bin play. Then I have families do a lot of incorporating the kiddo into meal times, and food preparation, right? Because a lot of our food preparation, it requires kids to come in contact with different textures. I bring in lots of different toys with different textures, walking across or crawling across different like textured floor spots, and then using vibration, which I know Carol had also mentioned. So vibration, toys that vibrate or vibrating toothbrushes or any of those kinds of things, that provides tactile and deep pressure input. And if you remember, that deep pressure input is the universal regulator, right? So that helps to regulate the sensory system while also providing tactile input. So that's a really good one to kind of combine for kiddos who are sensitive to tactile input. All right. So Sarah and I, we do co-treat for one of our kiddos right now. And I will say that working with the DTV has been amazing. I love collaborating about like how to adapt different sensory materials and sensory activities, modifying the kids' environment from a sensory perspective to help them to build skills in any area. In our co-treat sessions with OT and DTV, we target activities that work on pre-Braille skills. So, you know, kiddos are going to need to learn Braille as they get older. They're not learning it like before they turn 3, but we need to establish the foundation skills so that they're able to learn Braille once they're at the right age to start learning that. So some of the pre-Braille skills are listed below. And generally the pre-braille skills involve fine motor and sensory skills. So if kiddos are not comfortable exploring textures using their hands, then that kind of can really interfere with those learning activities. So kiddos need to be able to purposefully release objects into a container, into a hand that's like outstretched for an item. They need to be able to use both hands together. That's what bilateral coordination means, is using both hands to perform the same or different actions at the same time. Finger isolation, moving, getting that index finger out to point, poke, all that good stuff, instead of using the whole hand as one unit. And then that feeling of comfortability of it, being able to explore textures with open hands rather than keeping hands closed, out of kind of that fear of coming into contact with aversive textures. So that's it for my portion. Any questions in the chat, I will be happy to answer, and I will also be sharing my contact info if anyone has questions moving forward. Thank you.
Thanks, Sarah. So finally, we're going to talk about feeding therapy. And I'd like to introduce Kristen Faulkner. She is a speech language pathologist and feeding therapist in Central Illinois. And because our kiddos with ONH very often have feeding difficulties, I asked her to focus specifically on this area. So Kristen, take it away.
Thank you, Julia and Sarah, for having me today. It's an honor here to discuss the topic of feeding with children with optic nerve hypoplasia. I've been working as a pediatric feeding therapist in a variety of settings, from an inpatient setting at a children's hospital to outpatient setting in families' homes. And I've been involved in early intervention for 24 years and have had the pleasure to work with Julia during that time with several shared clients. When examining the population of children with a diagnosis of optic nerve hypoplasia, we statistically discovered that children are at an increased rate of presenting with a pediatric feeding disorder. These feeding challenges can be demonstrated early on with bottle feeding or nursing, while other children may present with feeding difficulties with the introduction of spoon feeding or textures of food. No matter when the feeding difficulty may arise, each child with ONH has their own unique journey in learning to enjoy meal times. As providers, we can identify some of the challenges that the child may face, as well as how to implement some key foundational strategies to help the child in their journey in learning to enjoy meal times. Children with ONH can present with feeding challenges related to their oral motor skill development, their sensory preferences, or feeding issues associated with hormonal difficulties. One of the key factors in looking at children feeding challenges that a child presents with is examining their oral motor development. When other therapists work with me, they often grow tired of hearing me say, what happens at the hips impacts the lips. I use this phrase repeatedly because it perfectly illustrates how children need to demonstrate the gross motor development to have the subsequent oral motor development to handle pureed foods or textures of food safely. Many of our children with ONH may be older when they learn to meet their gross motor milestones, as Michelle discussed earlier. The decision to introduce textures needs to be one that is based on developmental readiness in oral motor readiness rather than the chronological age of the child. The team needs to rely on the knowledge and input from our physical therapists, feeding therapists, parents, and pediatricians to help determine if the child has the gross motor skill readiness that would enable the child to be ready and successful with textures of foods. If the child's not ready from a gross motor perspective, then difficulty can be subsequently noted with successful feeding experiences. A child who does not sit well will have an increased challenge in accepting pureed foods from the spoon. A child who is not walking will have increased challenges in chewing foods like meats. What happens at the hips impacts the lips for our children with ONH, and this is the guiding factor to help determine the best timing of introduction of textures for safe and efficient eating at mealtimes. One of the other significant factors that contributes to a child with ONH presenting with feeding challenges relates to their sensory preferences that may contribute to a restricted food repertoire. Children with ONH are at a higher risk for oral and tactile sensitivities, just as Sarah was describing before. Feeding is an experience that is filled with many sensory surprises. A child with ONH may be overly sensitive to the touch, taste, and temperature of foods. It's often difficult to help prepare a child for temperature changes that are involved with new foods, and many children can have a narrow range of tolerance of temperature differences. Many children can face challenges with acceptance of variations in textures, with gagging or refusal of the texture noted if there's a texture change. For self-preservation during feeding experiences, the child may learn to avoid many tactile and oral interactions with food. As a result, their diet may become very limited. Once the hypersensitive responses have been developed by a child with a visual impairment, it may be more difficult to overcome these sensitivities if not addressed early on due to the added emotional component that's subsequently involved in their food preferences and/or refusals. A final challenge that we need to just keep in mind related to feeding with children with ONH relates to the hypothalamic dysfunction that can be seen with this population. Hypothalamic dysfunction can result in disruption in the homeostatic mechanism that impacts the pituitary gland function, temperature regulation, and behavior involving hunger and thirst. Growth hormone deficiency, hypothyroidism, and diabetes insipidus can impact children with ONH and be contributing factors to their feeding challenges, as their hunger and thirst needs may be different or fluctuating. As a result, it's imperative that as professionals working with children with ONH, that we are noting any changes with their feeding or drinking patterns and communicating this with the larger medical team to ensure that this is not a barrier to their success in learning to enjoy mealtime. Visually impaired children must be active participants and partners in the mealtime process. Adults who are working with a child must account for the visual limitations as they prepare the child for the meal. Infants and toddlers with ONH eat and grow best when they have a sense of control over the pace and timing of the meal. They need to be in control of what they let in their mouths and whether it's for bottle feeding or for spoon feeding. A sensitive approach needs to focus on following a routine, allowing the child to actively participate in the mealtime process, and be helped to try new things in a slow manner. Some of the potential difficulties with feeding can be avoided with good prevention techniques. To help accomplish this, there are 4 strategies that promote mealtime success for a child with ONH. First of all, preparation. The child with ONH needs to be prepared early on for the self-feeding process, beginning in infancy as the baby is guided to the breast or the bottle, and then moving to spoon feeding and eating of textures. It's important for the child to be an active participant in the mealtime process. To help the child see the meal with their hands, it's important to guide their hands through the meal, as well as offer opportunities repeatedly for that child to feel the adult eating, as the adult bites through different textures of food, as well as when the adult chews their food. Preparation is an essential foundational strategy to help children enjoy meal times. The second strategy is routine. A predictable, and I loved all of Carol's information from that, because that predictable mealtime routine is a key factor in helping to encourage mealtime success. Children may be acutely aware that mealtimes are approaching due to the smells and the sounds of the meal preparation. Communicating to the child what is being cooked is a wonderful strategy to help them know what to anticipate for the meal. Using a familiar song to help signal when it's time to move to the table for a meal. Having meals happen at the same time each day, with a child sitting at a specific table and a specific chair, along with ensuring that the utensils, plates, and cups are in the same position, will help contribute further to mealtime success. A placemat or a cookie sheet can be part of the routine to help define the parameters of the child's eating space and further help with their mealtime enjoyment. The third strategy involves encouragement of that exploration and mouthing, and I know Sarah touched base on this as well. Children with ONH should be encouraged to do a lot of mouthing starting early on in infancy. Mouthing of teether toys and toys helps prepare the child's mouth for the challenge of textures. It's important to help parents of children with ONH learn to help their babies explore their hands to prepare them for textures and transitions in foods. Once children are ready for taste and food introduction, the child with ONH will explore the new food with their sense of smell and touch before it will go to their mouth. It's important that parents and providers talk to the children about the foods that they're eating and being offered. Talking about the properties of the food, like it's crunchy, it's salty, it's soft, helps make the exploration of the food safe for the child. The child can be encouraged to smell or lick a food even before they taste the food. Involving children in the preparation of their food is a powerful strategy to have them more readily explore new smells, tastes, and textures of food. The final strategy for mealtime success is go slowly with sensory changes. Each food is a combination of different tastes, textures, and temperatures. The child with ONH may be willing to explore one of those, but maybe not all of those components of a food at the same time. The feeder may need to start with what the child's familiar with and move very slowly in making a change. For example, adding a tablespoon of homemade blended carrots to commercially prepared baby food carrots is a great way to start to introduce a different texture gradually to the child. It's also important to reintroduce the food if the child initially dislikes it. A child may reject a food initially by spitting it out. It may have been the taste, the temperature, or the texture. We're not sure yet. So rejected foods need to be reintroduced to perhaps with a slight change in them to adjust the temperature while you keep the taste or texture remaining the same, or vice versa. To ensure the most enjoyable experiences with food, it's crucial to proceed slowly and to monitor the child's responses for the taste, texture, and temperature of the food each step along the way to guide the child to the next steps in their feeding journey. So a child with ONH encounters challenges in the acquisition of feeding skills, as we've discussed. Collaboration with the DTV is essential for the child's feeding success, as the feeding therapist needs to understand the child's vision, including their depth perception, as well as the child's visual field. Julia has helped me numerous times to know how to best present bottles, utensils, or foods in the child's visual field. The DTV can help the feeding therapist establish the mealtime routines and knowing where to place those utensils, plates, placemats, or cups that best suits the child, which helps contribute to their mealtime success and eliminate the sensory defensiveness if these items are not placed in the child's visual field. With that collaboration with the DTV and use of the prevention techniques detailed above, some of those feeding challenges that we see with children with ONH can be avoided or diminished in order to promote their enjoyment as well as their family's enjoyment at mealtimes.
Okay. Thank you, Kristen. Again, that was a lot of wonderful information. So we will take questions here shortly. But in conclusion, I just really want to just quickly review that throughout the ONH series, part 1 and part 2, we have discussed the complexity of the diagnosis as well as the variety of strengths and challenges that children with ONH may present. That is why it is so important for us to collaborate with all professionals working with the child. All disciplines need to understand the diagnosis and the unique needs that a child with ONH may have. We can implement strategies throughout their day to help develop the entire child. As we just learned, we can implement strategies to help with their physical skills, their motor skills, their language development, their feeding skills, behavior and sensory needs, social skills, as well as the vision skills in the classroom and in the home. And all of us, all professionals can implement these strategies throughout the day to help work on the goals and for the child to be successful. So Julia and I want to thank you all for joining us throughout the series, and we would like to thank our guest panelists today for sharing wonderful information and being willing to join us today as well. So we will open it up to any questions. I know there were some questions in the chat and some of them may have already been answered, but we can open it up if anybody has any additional questions.
I see one for Kristen at the end. We're talking about an older student. Kristen, can you see that about suggestions for an older kiddo, middle school age?
Okay, so yes, I know, and I wish I would have a short, succinct answer to that. I think, first of all, I would want to know how that child is taking their liquid. Is it, I've had older students who are still on a bottle. And so knowing how they're taking that and seeing if maybe if they're on a bottle, seeing if we can start to have them move to a straw and a sippy cup. Okay, great. Thank you for that. And so I think part of it is that even as Sarah had talked about some of that exploration, having them, eating is a final step. There's more than 32 steps to get a child who is only, who is that selective in eating. And so we need to see if they can tactily interact with it. Can they smell the food? And so multiple repetition, having them interact with that food, presenting it multiple times, trying to see if they're responding to the temperature of that food. We know with that child who's on liquids at this point that it's harder for them to know how to chew foods if they're that old. And so really getting a feeding therapist involved to help you guide as well as what textures to present with that. But I think as much right now, I'd say a feeding evaluation by a trained pediatric feeding therapist, but at least working as well with the OT with some tactile exploration of some foods would be a good way to start.
Sarah, we saw a couple of questions that we wanted to address. One was about pre-Braille. And we did a pre-Braille webinar in the past, and it can be found on the APH website with the archived webinars, but it can also be found on our Illinois School for the Visually Impaired recorded webinars link that's right here on this page. It called Tips and Techniques for Pre-Braille. And so we hope that that's useful to you. And then we had another question about behavior support. And I think we did address a lot of that in part 2, just what we can do as DTVs. And I know the question was asking more for a team approach, but as far as what we can do with parents, we did have some suggestions. But if there are more questions, please feel free to contact us at our email or phone numbers here, because we'll be happy to tailor our answers to your specific questions if you contact us directly. Let's see.
Looks like there's a question for Carol asking if she could share strategies for collaborating with OT and PT in implementing ways that are best for a student to engage their sensory systems before beginning O&M.
Well, I always make sure that I visit with a OT or PT during a session. And I feel like they're sharing with me a lot of their strategies. I think about the sensory part. And then I'm giving them sort of the information that we're looking to find, whether it's concept development, vestibular movement, auditory, orientation. So I feel like we're working together. I'm not sure if I have the right, I don't know how to put it in words. I don't know, Julia and Sarah, if you could help me. Like, I know we've done some things before.
What specific things were we trying to talk about? I'm sorry.
Yeah, like how I collaborate with the OTs and the PTs.
You share a lot of video. You always ask like the families to share a lot of video if you can't be in the home. I feel like that's been helpful.
The stuff that Carol brings is helpful.
Oh, stuff. I'm sorry. I misunderstood the question.
No, they're both correct. I'm just saying that's for me. Carol is the one who I rely on to, to have the right push toward the right anticipator or the right size cane, because the parents sometimes don't know how to measure it. And so she makes sure that they're correct. And then guiding us in different types of outings that we do, going out into the community. So those are the fun ways that we're
just using other things in the home, like little chairs to push around, or, just like other things that not a cane. Maybe they don't have the push toys, but other things that can be used in the home too. I think the videos though have been particularly helpful because they're not just shared like when we're in the home. And so a lot of my families will share videos, just at random times when when their child's doing something that I think gives Carol a lot more information too as to how to move forward.
Yeah, I find that if I ask the parents to send me, a lot of times Sarah or Julia and I will be on a Zoom and the child isn't doing what we want them to do. And so, you feel frustrated at times. But then recently I got a video from a mom who sent me a picture of her little boy trailing the wall, kind of exploring. Like, I didn't think he was doing that on his own. And she kept saying, oh, yes, he does it all the time. And of course, just like right now today, he's not going to do it for you. But then, I sent that video back to Sarah. It was like a Friday. I mean, it was a day that neither of us had seen the child. And so incorporating that and then sharing that information with the OTs and the PTs, I find helpful. And I specifically have a PT that I work with. How Julia and Sarah have people that they work with in their area. I have some up in the Chicago suburbs. And sometimes I will just reach out to them if I have an issue with a child that we just can't find what it is to motivate them. And oftentimes it's just, they get there, but it is just finding what is that motivator for them, and most of the time it's music, honestly, whether it's singing or their parents' phone with their favorite song.
That's true. And that is just us getting to know them. So like, let's say we see them on a more frequent basis, or a different therapist sees them on a more frequent basis. They might have that clue. What is that thing that motivates the kiddo? And so we all try to share that so that everyone's on the same page with that. You see any more questions?
There was a question, I'm trying to find it, something about a least restrictive environment.
Oh, in the classroom?
Mm-hmm.
Well, that's a stretch for us because we're birth to 3, but we are parents of students with visual impairments. And so I'll just tell you, take off teacher hat, put on mom hat for a minute. For my own kiddo, she doesn't have ONH, but she did have severe sensory issues when she started school. And so what they did was just a lot of breaks and also a tent. So they had a little sensory tent for her for when she just really needed to block out a lot of the visual clutter of the room, and it kind of dimmed some of the noise, and just to give her her own little space where she could just have lower sensory. But a lot of times today she goes for a walk down the hall to get her out of her busy sensory environment. That really helps her a lot. But I mean, there are lots of different creative placement options depending on how flexible your school is, where you could do, part of the day in a less busy environment and part of the day in a more typical LRE type environment. So like, if you want to email or chat, I can try and throw more suggestions at you. But like I said, we're birth to 3, so we don't have a lot of experience with classrooms, but just wearing our mom hats, we can give some advice possibly.
I did have, similar to Julie, I had a child transition into a classroom that did turn one corner of their classroom, an early childhood classroom, basically into a sensory room. Like, they tarped it off. They were able to control the lighting. So if the child kind of needed to be removed into a quieter area, they were able to do that in this particular classroom, and that seemed to help quite a bit.
Yeah, and I see it's a preschool kiddo. So yeah, preschools are often way more flexible.
Yes.
And you can do in and out of the classroom. So that'll be just, yeah, I would suggest sensory safe space and lots of frequent breaks, or perhaps like a mixed placement.
Right.
There was a question about coaching that I just saw as I was scrolling through, and here in Illinois, and as well, I know as in all over the country, the earlier intervention is, preferring for us to use a coaching model. It's like, leave your bags at home, don't bring your toys, and do that. And so somebody was asking like how we do that. And I will just give a brief little summary in terms of like orientation mobility. If we're out of the home, which oftentimes if I'm working with a family that has a child that's already familiar with the home and they're working on using some sort of a tool in the community, then that gives me the option to be able to like follow along on a mobility lesson as if I were following a student teacher in a way. I mean, I'm letting the parent and the child hold hands and walk together and talk about, verbalizing the change of surfaces that might be in front of them or the sounds that we're hearing. And I feel like it's a little bit different using the coaching model when you don't, I always go to the home with nothing. And so I want to use the toys that they have. And so if we're in the house, we're going to play, we're going to talk about the concepts that we, in and out and up and down and rough and smooth. We're going to do all of those things with whatever it is that's there. But I feel like sometimes I am just like sitting back, and the parents, once they get familiar with what we are and what we do, I feel like that's a lot easier. Some parents don't like that model, and it's often difficult. I have a child I just saw this morning in a daycare center, so that model isn't working for us, the coaching model. And that's some things that we have to deal with.
Yeah, that is a challenge. I kind of answered that question differently, just saying how it is supposed to be a parent-led process, but the parents can't lead when you just start with them, right? Like they're just at the beginning. They have to learn slowly and gradually, and incorporating what they know about their child with what they're learning about visual impairment and possibly other disabilities that might be addressed by our other specialists, along the way. So I feel like at the beginning, it is a lot me teaching the parent. And then as we go, the parent is taking over for me more and more and more. And that day when I walk in and I don't feel like they need my help at all is the best day of my, working with that family. I'm so excited that the parent has it, like they have it. But I have to say with Carol, I'm not as good as Carol at not bringing things in, but I do try to bring in things from the dollar store that are inexpensive or things similar to what parents have in their home. I just think that because, Sarah and I have been doing this for so long, we have a good idea of what might motivate certain kiddos, what types of textures, what types of sounds. And, if we find a particularly cool toy, we're telling each other about it. So we might bring that in just to give examples to parents, just to give them a place to start. Because and we both remember that starting point where you're, new to all of this and you need to, have someone welcome you into this field and kind of give you a path to walk. I think we have more come in. Okay.
I did see one question. Somebody asked if part 2 covers self-stim behaviors. Yes, it does. Our part 2 is all about strategies that cover all of the areas, like behavior, sensory needs, language, social. So that would be a good one to check out for self-stim behaviors. And again, if you have questions, Renee, you can always reach out to Julie and myself afterwards.
Okay, I'm not seeing anything new come in. Any last questions from anyone? You can ask any of our guest speakers. So Kathy, the link that's on our page here has parts 1 and 2, and also Melissa shared the APH link to our parts 1 and 2. So absolutely, you can go back and watch those first 2 webinars. You're welcome.
I can't thank you guys enough. This series has been phenomenal. And I know I've heard a couple of things in the chat about wanting more. So I have no doubt that some other things are probably in the pipelines to be worked out as we reflect and move forward. But I just want to thank you for all of your information and everything that you have provided.
Can I thank my guest speakers? Thank you
Absolutely.
for helping us out today, because we wouldn't be where we are today without our teams, right? We all worked so well together. So we are so grateful that you were here today to share your expertise.
Absolutely. Thank you.